I'd like to introduce you to our speaker this evening, Dr. Sara Kulangara. Sara, if you could turn your camera on and join us. So Dr. Sara Kulangara is a cardiologist with Virginia Heart who specializes in general and nuclear cardiology. She is also very skilled in the use of echocardiography for diagnostic purposes of a variety of cardiac conditions, and she is board certified in cardiovascular disease. Dr. Kulangara earned her medical degree from the University of California at Los Angeles and pursued her medical residency at Brown University in Rhode Island. She then completed her fellowship in cardiovascular disease at the University of North Carolina in Chapel Hill. Dr. Kulangara sees patients in Virginia Heart's Loudoun and Vienna offices and sees patients in Inova Loudoun Hospital, as well as Inova Alexandria, Fair Oaks, and Fairfax hospitals. She is part of a team of 19 physicians who compose Inova's Women's Cardiovascular Health Program, and I'm sure she's going to explain that to us this evening. Dr. Kulangara, the floor is yours. Thank you.
Thanks, Dr. Levy, for an introduction. It's been a pleasure working with you for over 20 years at Virginia Heart. And thanks to Inova for giving me this opportunity to raise community awareness on reducing cardiovascular risk. I'd like to share a personal experience to start a discussion.
Sara, I think you're going to need to share your slides at this point. If you can get those up, that would be great.
Sure. And there we go. On April 10, 2 weeks ago, my aunt had a heart attack out of the blue. She had chest discomfort the day before, which she attributed to a gas problem. It subsided on its own. The day of her heart attack, she felt an unusual pain in her leg and went for a massage. The chest pain returned. She heeded the warning and went to the hospital to be evaluated. My uncle later said, "You just don't hear about women having heart attacks." For those of you that have received this kind of call about a loved one in the middle of the night, you will recognize that empty feeling in your stomach, the cold, sweaty palms, and recognize that my aunt just opened the door to face cardiovascular disease. So the question is, what is cardiovascular disease? It's a broad category encompassing coronary artery disease, heart attack, heart failure, arrhythmias, stroke, and peripheral arterial disease. These entities often have roots in early life provoked by poor diet, sedentary lifestyle, emotional stressors, and erratic sleep habits. They set the stage for development of hypertension, diabetes, lipid disorders, and use of tobacco products. Cardiovascular disease is the #1 killer of women. 44 million women in the US are living with some form of cardiovascular disease. 90% of women have at least one risk factor. Only 44% of women recognize that cardiovascular disease is the greatest risk to their health. And less than 50% of women entering a pregnancy have good heart health. 10 to 20% of women have a heart issue during pregnancy, and there is a 2.6-fold higher incidence of cardiovascular events in postmenopausal women than in their premenopausal counterparts of the same age. As it turns out, cardiovascular disease tops cancer, lung disease, and Alzheimer's, as well as diabetes, in mortality risk. It's more common in men under the age of 64, but changes to become more common in women over the age of 64. So now we need to recognize the signs of a cardiac event. Symptoms of a cardiac event include chest pain, which may feel like pressure, squeezing, burning, or tightness, shortness of breath, radiating discomfort to the jaw, neck, or back. These are most commonly found in men. However, in women, additional signs may include sleep disturbance, unusual fatigue, sweating, or a sense of indigestion or nausea. Too often, people turn to Dr. Google or WebMD to diagnose their condition. If it is sudden and unexplained by immediate circumstances, you should seek immediate attention. It's estimated that 80% of deaths from cardiovascular disease in women are preventable. So this is where knowing your numbers is critical, and acting on that information can be life-saving. What are the risk factors? Ranges on this slide are estimates based on average population. Some people live at a lower blood pressure, some people live at a slightly higher blood pressure. I always encourage people not to react to a single reading, but to look at trends as well as averages. Normal blood pressure ranges from 90/60 to 120/70. Elevated blood pressure exists when the systolic reading is between 120 and 129, and the diastolic reading is less than 80. Stage 1 hypertension is when the systolic reading is between 130 and 139, or the diastolic reading is between 80 and 89. Stage 2 hypertension is categorized by a systolic reading over 140 or a diastolic reading greater than 90. A hypertensive emergency for which you should seek immediate attention is a systolic reading greater than 180 and or a diastolic reading greater than 120. Other risk factors include elevated fasting blood sugar. This comes mainly from carbohydrates in food and drinks. A normal level is less than 100. There's a test that looks at the average amount of sugar in your blood over several months called the hemoglobin A1C. A normal level is less than 5.7. Pre-diabetes is when the hemoglobin A1C is 5.7 to 6.4, and diabetes exists when the level is above 6.5. Optimal cholesterol levels include a total level less than 200, triglycerides less than 150, LDL less than 100 in the general population. For patients with cardiovascular disease, we have more strict targets for LDL, ideally less than 70 and sometimes less than 55. The HDL or good cholesterol target is greater than 40 in men and greater than 50 in women. Much has been made of the body mass index, and normal is less than 25. This is based on the height and weight of an individual, but does not take into account muscle mass, bone density, overall body composition, and racial or ethnic differences. This was originally developed in non-Hispanic white males. More progressive estimates include waist circumference and total fat tissue that can be assessed by a specialized DEXA scan. Tobacco use contributes to increasing cardiovascular risk. Family history can influence your risk profile, and it generally means a parent or sibling with the cardiovascular event under the age of 55 if male, and under the age of 65 if female. Additional risk factors include sedentary lifestyle, age, race, or ethnicity. Non-traditional female-specific risk factors include hormonally mediated entities such as pregnancy-induced hypertension, preeclampsia, gestational diabetes, and prothrombotic states, or increased tendency to clotting with supplementation such as oral contraceptives, and hormone replacement. We know that estrogen is protective in delivery to reduce bleeding, but may be harmful in the wrong circumstances at other times. Treatment of breast cancer can be a risk factor. Certain chemotherapeutic agents are linked to heart failure and radiation to blocked arteries and heart valve disease. 80% of cases of autoimmune disease are in women. This is a category that includes lupus, scleroderma, rheumatoid arthritis, and thyroid disease, as well as many others. Some of these entities have direct links to cardiotoxicity and development of cardiomyopathies. Others have a link to developing conduction system disorders and arrhythmias. Depression occurs at a higher incidence in women as compared to men, and there's also a higher incidence of depression in patients who have had a cardiac event. Now that we have an overview of individual risk factors, how do we use that information to estimate our risk of heart attack? I'd like to describe two important risk calculators that help define the long-term risk of a cardiovascular event. The PREVENT score calculator stands for predicting risk of cardiovascular disease events. It was introduced last year to incorporate risk factors into a formula that estimates the likelihood of a heart attack, stroke, and heart failure in an individual over the next 10 years and 30 years. It's based on data from more than 6 million US adults from a variety of racial, ethnic, socioeconomic, and geographic backgrounds. It can be used in people ages 30 to 79. Factors include sex, age, cholesterol, blood pressure, body mass index, eGFR, which is a measure of kidney function, diabetes, smoking, and use of a blood pressure or lipid lowering medication. These place people in stages of cardiovascular kidney metabolism. Stage 0 is this segment of the population with none of the risk factors. Stage 1 includes people with excess body fat, abdominal fat, or prediabetes. Stage 2 includes people with type 2 diabetes, hypertension, elevated triglycerides, or kidney disease. Stage 3 includes stage 2 plus early cardiovascular disease or high risk for cardiovascular disease. And stage 4 is stage 2 plus symptoms of cardiovascular disease, such as heart attack, stroke, or congestive heart failure. As one of my patients said, it's better to screen for the risk factors than to call 911. If you're getting to stage 4, we'd like to really avoid that and treat things in earlier stages. When we talk about a healthy metabolism, we're talking about the following factors: maintaining a weight that's healthy without wide fluctuation, feeling energized throughout the day without extreme highs or lows, eating a well-balanced diet rich with healthy proteins, fruits, and vegetables with limited cravings for higher sugar or fatty foods, having enough energy to exercise regularly, and possessing a clear, functioning mind. The staging categories incorporate knowledge that the risk of cardiovascular disease rises as kidney function declines. There are 2 subdivisions of stage 4, which include stage 4A without kidney failure and stage 4B with kidney failure. Treatment options are a little outside the scope of this talk, but I will mention that a class of medicine known as SGLT2 inhibitors directly address reducing metabolic risk. They were originally developed to treat diabetes. They promote weight loss, lower blood pressure, and help prevent kidney damage, even in people without diabetes. They also have a cardiovascular protective benefit, especially in people with heart failure. Another class of diabetes medication known as GLP-1 agonists promote even more dramatic weight loss. One other biomarker for cardiovascular kidney metabolism syndrome emerged from this project in the urine to albumin creatinine ratio. This detects very small amounts of a protein called albumin in the urine, which impacts cardiovascular risk. Let's turn to another important measure of atherosclerosis, which can be incorporated into the risk calculation. Coronary artery calcification. About 1% of calcium in the body is present in the bloodstream. It supports healthy muscle contractility in the heart. After age 40, it starts to build up in the coronary arteries, which conduct blood supply to the heart muscle. When it progresses, it is called atherosclerosis, which translates to the more common term, hardening of the arteries, with which we're more familiar. The coronary artery calcium score is assigned based on the degree of calcium deposits in the arteries that supply the heart muscle. So the next question is, how do we use this number? This is the basis for the multi-ethnic study of atherosclerosis. This was a population-based research study of 6,814 men and women without established cardiovascular disease. It includes white, Black, Hispanic, and Chinese individuals recruited from 6 cities across the US. The age range is 45 to 84. This calculator includes traditional risk factors in coronary artery calcium. It provides an estimate of the 10-year risk of a heart attack, cardiac arrest, symptoms due to a blocked artery that require a procedure to restore blood flow, or death due to coronary heart disease. This allows patients and physicians to develop strategies to lower cardiovascular risk. These strategies always begin with lifestyle modification. This is why it's extremely important to know your numbers: blood pressure, cholesterol, blood sugar, and body mass index. In appropriate cases, the PREVENT risk score, or MESA calculated risk score using your coronary artery calcium level, may be helpful. I'll just mention a couple other measures. One is the high sensitivity C-reactive protein. This is a protein made in the liver in response to inflammation. An elevated reading may be the result of infection, chronic disease, or trauma. It has been linked to increased risk of heart attacks, but is not as specific to the cause of inflammation. It's most helpful in patients with an intermediate risk of heart attack, approximately 10 to 20% in the next 10 years. Levels can be variable, so they need to be repeated at least 2 weeks apart to confirm abnormalities. Another test is the apolipoprotein B level. This is a transport carrier for LDL, VLDL, and substances that help create plaque in the arteries. Each apolipoprotein B molecule carries one of the bad lipoproteins, and therefore may be more accurate in determining load than a routine lipid profile. It's most helpful in patients with metabolic syndrome or diabetes because their LDL may be smaller or more dense. The range is 220 to 400 milligrams, and if your level is above 130, you're at higher risk for heart and blood vessel disease. Healthy habits to mitigate cardiovascular risk are to eat a healthy diet with predominant vegetables, healthy proteins, healthy fats, and limited carbohydrates. To be more active, to try and get 30 minutes of exercise 5 days a week at a minimum for 150 minutes. To completely cease tobacco use in any form, including chewing tobacco. And to get adequate sleep. We recommend 7 to 8 hours on average. We want people to maintain a healthy weight and to control their cholesterol, manage their blood pressure and blood sugar. In summary, regular checkups save lives. Thank you for your attention. The information on the Inova Women's Cardiovascular Health website is available to you. And we're all here for you to help you through this journey and hopefully successfully avoid developing any cardiovascular disease or have to face anything like my aunt had to. So closing the loop on her situation, she is doing quite well, recovering from her heart attack. She's actually a retired physician, and she knew her numbers and knew her risks, but genes caught up with her. But I think recognizing the symptoms saved her life. And I hope this presentation helps all of you live a much healthier and happier life.
Thank you very much, Sara. That was great, and we're gonna get into questions. If you want to take down your slides, and that way they can see us a little bit better. Thank you. So I'm going to go back to, I think, what's really one of the most important things, and just so maybe you could do it again. We always talk, you made the point that women are not immune from cardiovascular disease. In fact, more women die from cardiovascular disease than anything else. And most women don't know that. But the thing we hear a lot is that women have symptoms that are different than men. And that's one of the reasons that it can sometimes be a little bit more difficult to diagnose, especially coronary artery disease in women. But then a lot of patients will ask me, well, if I'm feeling a little lightheaded one day, should I run to the emergency room? Does that mean I'm having a heart attack? Right. So when should you be worried? What are the symptoms that are different than the classic elephant sitting on your chest that we think of, especially when men are having a heart attack? What's the take-home message for all the women who are listening to you tonight?
Well, I think you have to take your symptoms in context. So if there's something unprovoked and unusual, if it's chest discomfort that you can't explain, sometimes it's discomfort between the shoulder blades or in the jaw in unusual locations, and there's no great explanation for it, it's time to get attention. If you have something that's more severe and it's persisting, then you should get emergency attention. Sometimes I have patients come in complaining of unusual fatigue, and we look into it. We don't just write it off. Stress testing, and we have lots of different measures of how to assess that. But it's really important to get things checked out, not to dismiss your symptoms.
Yeah, basically, it's always better to err on the side of being cautious. No one's gonna criticize you for coming in for an evaluation if you're not sure about your symptoms. A couple of questions about, you talked about one of the potential risks for developing cardiovascular disease are women who do have breast cancer and receive chemotherapy. There was one question about tamoxifen. And if you are a woman who's had breast cancer, who's had chemotherapy, is there anything special you should be doing? One of the questions was, well, should those folks be taking aspirin even if they don't have any known vascular disease?
I think the literature on taking aspirin proactively is now favoring not doing that unless you have established vascular disease. There's been data to suggest that the increased risk of bleeding associated with long-term aspirin use is not outweighs the potential benefit when you don't have established vascular disease. So it goes back to getting the testing and seeing the cardiologist to figure out whether the treatment has influenced your risk in an adverse way.
Yeah, that's one of the times that the press can really confuse our patients when that recent study came out that said patients for primary prevention should no longer take aspirin. A lot of our patients who needed to be on aspirin got confused and thought that meant that they could stop taking aspirin. So the take-home message is anyone with vascular disease should probably be on aspirin, but you shouldn't take aspirin just to prevent a problem if you don't already have it.
I might just add that for the audience, the vascular disease we're talking about is not just heart disease. It could be a prior history of stroke or peripheral vascular disease as well.
There are some general cardiology questions out there, but I think we do see this more often in women than men. Low blood pressure or blood pressure that falls when you stand up and you move against gravity. Someone wanted to know, what can you do about someone who has low blood pressure, which is a cardiovascular issue. We call that orthostatic hypotension. What do you recommend for that?
I see that quite often in some of my younger female patients. And one of them actually joked and said, well, when I turn 40, this will go away. And some of it does have to do with your vascular tone. What happens is the blood sort of pools in your extremities when you change position, and the regulatory mechanism that occurs in the brain doesn't quite correct for it as quickly as you would like in some individuals. So some things you can do are intentionally salt load. I had one patient tell me that she put salt in her coffee in the morning, which sounded horrible, but seemed to work for her. There's V8 juice and other things that have a lot of salt, and it's rare that you'll have a cardiologist recommending a high salt load, but in these particular circumstances, it may be helpful. The other option is to wear compression stockings. That sometimes helps avoid the blood pressure dropping as significantly as it might otherwise. And then there are counter pressure maneuvers where you actually sort of squeeze your muscles in the legs to prevent the blood pooling when you change position.
Sure. Several questions about coronary artery calcium scoring. You talked about that as one of our diagnostic tools. First of all, I'll ask you, when do you recommend that patients get a coronary calcium score? Should everyone be getting coronary calcium scores? We can get into some policy discussion there. And if you've had one, how often should you repeat it?
Yeah, it's a useful measure, but I don't think everyone should get it. First of all, the population base was between ages 45 and 80. So outside that realm, the data is not going to be as helpful in terms of comparing you to a population base. Also, if you have traditional risk factors that need to be treated, like a very high cholesterol with an LDL of 190, you really don't need a calcium score to address that aspect. So we also don't use calcium scores for diagnostic purposes when people are having symptoms per se. We use it more for screening. So that gives some suggestion. As far as how often to repeat it, about 8 to 10 years has been one of the formulas proposed to relook at it. But there's some data that your calcium score goes up when you take statins. So repeating it may not be the most helpful.
Yeah, I mean, I often use it for those patients who have borderline lipids, and you're kind of on the edge, should this patient be on medication or not? It can be a real tiebreaker, or people with significant risk factors. But once you have an elevated coronary calcium score, which tells us there's something going on in your coronary arteries, you need other types of testing. Follow-up coronary calcium scores don't really give us all that much information. Pregnancy and later developing cardiovascular disease, several questions about that. And I think you mentioned that developing eclampsia or preeclampsia during pregnancy is a risk factor. Is that is that a risk factor that lasts their entire life?
We know that patients have a fourfold risk of developing hypertension and heart cardiovascular complications 10 years later, so at least a decade later after their index event. And so they do need to be followed. It is something that is for life, and checking blood pressure, cholesterol, blood sugar, and controlling these risk factors, adopting a healthy lifestyle is something that will mitigate against that in a large part.
Yeah, I'm going to just comment on a question here. When we talk about coronary calcium scores, that has nothing to do with the calcium in your bones or the calcium on the blood test that your doctor gets. That's due to inflammation inside the artery. So people are saying, should I take calcium, not take calcium? Should I get calcium blood levels? That's a totally different animal and not related to coronary calcium scores. A couple of general cardiology questions, but it's important for people to know, is leg swelling, can that be an indication of any kind of a heart problem?
It can be. It can be related to blood pooling in the extremities because of poor circulation. One aspect is what we call venous insufficiency. So blood doesn't get returned back to the heart the way it should. The other place where we become concerned is when it's related to poor pump function or congestive heart failure. And that's an entity where we have to look at heart function and see if there are other associated signs. Sometimes we have to do an echocardiogram or ultrasound of the heart to measure heart function in that case. And it has to be taken in context with what other things might be contributing. If you have peripheral neuropathy and poor vasomotor tone, sometimes people get swelling from that. So it depends on what type of swelling, how long you've had it, and what other factors might be involved.
Here's a great question, because this is a really tough one to answer. And we all struggle with this as physicians and patients. How do you know the difference between indigestion and heart pain?
Yeah, that
Right?
is a tough
Yeah.
one. I have had patients popping Tums all night and suffer through a heart attack and present late. And I've had the opposite occur where people have come to the hospital thinking they're having a heart attack, and it's actually esophageal spasm, which is muscle spasm in the gastrointestinal system. So it can be very difficult to discern. And I think, again, this goes back to if you have symptoms that you don't recognize and you can't find a reasonable cause, you should get attention, because if it's difficult for us to figure out, we wouldn't want people to try and figure it out at home on their own.
Yeah. You did mention, I believe, in your talk that women's risk of cardiovascular disease and coronary disease especially goes up after about the age of 60. It exceeds men. But what role does and you also talked about hormones, but some folks want to know, what role does menopause play? And if a woman goes through menopause at a younger age, does that change the milieu for her?
Sure. Estrogen has an impact on a whole host of things. If you go through surgical menopause or premature menopause, you will be subject to some of the metabolic changes that occur for others later in life. And that can include elevation of blood pressure, changes in cholesterol metabolism. To some people get higher cholesterol, some of the contributing factors toward developing early cardiovascular disease.
Yeah. There's a question here I almost want to answer. So if someone had a coronary calcium score of 0 and then had a heart attack, how's that possible?
It could be coronary vasospasm. Sometimes people have spasm of the arteries that can cause heart attacks. It could also be from an entity called Takotsubo cardiomyopathy, a stress-related event that releases a lot of adrenaline and can provoke heart damage from that. And that is actually more common in women. could be from a coronary anomaly. Sometimes in younger patients, there are entities that have different, the coronary anatomy is different than normal, and coronaries course through a way where they can get compressed in an adverse way and cause a heart attack. And then there's something called spontaneous coronary artery dissection, which is an entity sometimes occurring in pregnancy where the wall of the artery gets disrupted and blood enters the space between that wall and can cause a heart attack. So there are many ways that people can have heart attacks without having atherosclerosis or coronary calcification as a contributing factor.
Right. Spontaneous coronary artery dissection is a major issue for in young women. I mean, I think the only young women I've seen during my career who've actually had cardiac events, and that's been the cause. The other thing is, and this is the reason we don't recommend coronary artery calcium scoring before the age of 40, because the plaques, that junk that builds up inside the arteries is soft. And before it calcifies, it can actually be less stable. And those plaques can rupture and cause heart attacks. And when you're on statins, it does increase your coronary calcium score, but stabilizes the plaque. So it has less of a likelihood to rupture. So there's a lot of reasons, like Dr. Kulangara said. Pain in your calves when you're walking, could that be a heart problem or a vascular problem?
Sure, that could be classic claudication, which is narrowing of the blood vessels in the extremities, and it can be influenced by the same process that occurs with atherosclerosis in the coronary arteries.
And someone said, can you get, they said calf pain, but I'll generalize that to muscle discomfort when you're taking statins. And for those who can't take statins, are there alternatives? Two different questions.
So there is a small percentage of population that gets muscle pain with statins. It's not necessarily when you walk, it could be more at rest or at any time, really. As far as alternatives, there's several alternatives now. There's non-statin medications such as Zetia or bempedoic acid, or there's actually a very good class of medicines known as PCSK9 antagonists that are injectable agents that have been used to reduce cholesterol dramatically, and very helpful in people who have familial hypercholesterolemia who may be intolerant to statins.
All right, I'm going to give you the option to say I pass on this question because it comes up in every single webinar. It's going to be about alcohol. Is alcohol good? Is alcohol bad? For men versus women, is the relative risk of alcohol consumption is it a risk factor for coronary disease or any heart problem?
It's a tough one, but I think you have to individualize your risk factor profile. That's one of the things about giving this talk, is that we give broad categories, but some people are very sensitive to small amounts of alcohol. Some people are not as sensitive to alcohol. There's all kinds of recommendations about it. There may be a cancer risk or a gastroesophageal cancer risk that you have to be worried about. I think you have to look at your family history and your individual profile. One of the places where alcohol seems to have a negative impact is in rhythm disorders. More common, people with atrial fibrillation, for instance, we're commonly advising them to reduce or eliminate their alcohol intake because it acts as a stimulant and can provoke heart rhythm problems. So there's places where it doesn't, it isn't a good player, but I think that's something you have to look at on an individual basis.
There's a question here, and thank you for asking it, which conflates two things. Left bundle branch block and rhythm abnormalities. A bundle branch block, which is not a physical block, it's just an electrical delay, is not a rhythm abnormality, but is a left bundle branch block something you're concerned about for other underlying cardiovascular issues?
We do look at if there's a structural issue that might be provoking it, or a circulatory issue that might be provoking it. So we would generally investigate that with an ultrasound of the heart or an echocardiogram, which will tell us if there's anything structural that might be involved. And when we see a left bundle branch block, we want to make sure coronary circulation is adequate.
And what's a heart murmur? Is that a risk factor for having heart problems?
Not necessarily. A heart murmur is a sound we hear when we listen to people on examination. It can be due to a heart valve problem, but it can also occur in lots of other entities, such as high output states. If you have a fever and your heart is pumping more blood, you may hear a sound that is a murmur. If you're anemic, or if you have thyroid problems, sometimes if you're hyperthyroid and your heart is working harder, you may hear a murmur. So it depends on what goes along with the murmur.
I'm gonna a couple of questions here about hormone replacement therapy, and I think you already said this is sort of an individual decision between a patient and their doctor, and looking at various risk factors. But what are the concerns if someone has other risk factors for cardiovascular disease? Is hormone replacement therapy something that they should back away from, or is that more relative to their risk for other, breast, uterus, ovarian issues?
That's a tough question to answer. I think the data is a little murky here. I usually would tell people that if they're having very serious postmenopausal symptoms, then hormone replacement is a reasonable choice, but it needs to be sort of for some time frame, not indefinitely. I think the risks potentially could be higher when it's long term, and short term to bridge very severe sleep disturbance or excess sweating or other sort of autonomic stressors on the body. It may be reasonable.
A lot of questions about cholesterol and cholesterol treatment, and when should I be on a statin? Again, these questions. What would you say are sort of the big picture guidelines for who should be on a statin?
I think certainly people who have familial hypercholesterolemia, if they have very high cholesterol and they have an LDL over 190, that's a definite indication for lipid lowering therapy, statins being the first line. If you have a cardiovascular event such as coronary disease or strokes or mini strokes or peripheral vascular disease, and your LDL is above 100, that's an indication to be on a statin and lower your risk for secondary event. And if you haven't had a primary event and you don't have very high cholesterol, another category we're more aggressive is if you have diabetes, because we consider that to be a coronary equivalent, if you will. Those are sort of the broad categories.
Is a woman who has had both a hysterectomy and an oophorectomy, meaning her ovaries were removed, does that become a risk factor at a younger age for potentially developing cardiovascular problems?
It is because it's essentially surgical menopause or premature menopause, because you're withdrawing the estrogen component when you remove the ovaries.
Boy, this is going to be sort of way outside women's heart health. We'll see if one of our interventionalists or electrophysiologists want to jump out of your ear and answer this. But is there an alternative to taking Eliquis or any other blood thinners? And I'm going to guess that potentially this is for a heart rhythm abnormality like atrial fibrillation.
There are other alternatives in the same category, Pradaxa, or the generic is warfarin, but we like to use the novel anticoagulants if we can. Xarelto is the other option.
And the other alternative, and I have a funny feeling that they may be fishing for this, is for patients who cannot tolerate anticoagulation. There is a procedure called the Watchman procedure, in which a little device is put into the right side, the left side of your heart, closing off what's called the left atrial appendage, which is where clots tend to form in the heart. So if you need to be on a blood thinner, but you can't tolerate blood thinners because you've had bleeding problems, then you should speak to your cardiologist. A bunch of questions about who should see a cardiologist, when should I see a cardiologist, if I have risk factors, or I've had issues of pregnancy, or something. When should I be seeing a cardiologist? Is it necessary?
I think if you have a primary care physician that you can work with well, and you know your numbers, then you're going to be an informed patient, and you'll be able to get to where you need to without necessarily having to see a cardiologist. However, I am a strong believer in people getting screening. I see lots and lots of women who get mammograms but never get a stress test. And I think when you see a cardiologist, we're going to be more likely to be proactive in that regard. We're also going to be perhaps a little bit more strict about lowering some of the risk factor profiles because of the patient population that we see. So I think it's reasonable to see a cardiologist, particularly when you're approaching your 50s or 60s, if you're not having symptoms, of course, if you're having symptoms much earlier. But we would love to see those patients and get them on the right track before they develop a problem.
Again, we're back to statins, but once on a statin, always on a statin. Does the statin cure the problem and then you can stop it, kind of like taking an antibiotic for an ear infection?
Unfortunately, it doesn't stop the problem. It treats the problem, much like blood pressure medicine treats blood pressure, or diabetic medication treats diabetes. Now, I will say that some patients who make significant changes in their lifestyle are able to come off statins, but it really hinges on how high the cholesterol is and what you do with your lifestyle.
Yeah, so many of my patients, they want to beat themselves up thinking that their high lipid numbers are all their fault. But I think most people need to remember that your cholesterol numbers, your LDL, HDL, part of that is what you're eating, but a lot of it is genetic. It's what you're producing in your liver, and it's how you're put together genetically and enzymatically. And generally, they say with diet alone, you can really only drop your cholesterol 10 to 20%. And so, unfortunately, if you really need to be on a statin because you have vascular disease, you have very high cholesterol, until we have something new, and there's always something new, and then things change, but yeah, you're going to be on it lifelong, more than likely. Can you describe, Sara, you've talked about it a little bit, but people hear these terms, and just to clarify, what is peripheral arterial disease, or PAD, PAD?
It's a similar process that goes on in the coronary arteries. It's basically buildup of fatty plaque or lipid-rich plaque in the arteries to the extremities, to the legs, sometimes more rarely to the arms.
And someone asked this question, and I think they're indirectly asking a post-COVID question. They're saying, have we seen an increase in seemingly young, healthy people in the last 3 years developing cardiac issues?
I would say that it certainly feels that way. I think I'm not sure if it's directly related to COVID or some of the stressors that have been going on with the isolation and the ambient stress in the environment, having to face the infection.
Yeah, actually, it's interesting that question came up. I was just at a medical meeting last week, and this came up, and there was some data showing that there's been an increase in what we call POTS, postural orthostatic tachycardia syndrome,
Right.
since COVID, and that is sort of that orthostatic hypotension, blood pressure falling when you stand up, but really to an extreme, and heart rate increasing. And it's felt that the COVID virus has had an effect on our autonomic nervous system. And folks who treat POTS are really seeing a huge increase in the number of cases. So yes, COVID, did lots of things to many different organ systems. And if you are having that issue, you should really see your doctor. So if I have a family history of heart disease, should my children see a cardiologist when they're young?
It's not a bad idea, especially if they have a valve problem. There's certain familial genetic syndromes that occur, and getting checked out by a cardiologist when you're young is probably a reasonable thing to do.
Yeah, especially with the really high familial hyperlipidemias, the really high cholesterol levels that are in families. There was one here. Oh, do you have a favorite? And there's no absolute here, and sometimes I'm amazed at how little we actually know about diet after all these years on this planet. But do you have a favorite diet that you recommend to patients as a heart healthy diet?
I usually talk about employing the Mediterranean diet, which is a 3/4 plate vegetable, a 1/4 plate protein, minimal carbohydrates, minimal dairy because they are inflammatory. But I also think that we're going to develop over time a much more personalized approach to what diet suits what person. I think that genes probably play a role in this, and we just haven't quite figured out what's going to suit people. But that's a general recommendation: an anti-inflammatory diet with more fresh fruits and vegetables as being the main source of your calories.
I'm not aware of any data, but do any statins or really almost any cardiovascular medications have a risk of increasing cancers later in life? That's a tough question.
I haven't heard that data, but I'm wondering if that was related to uh, there were some recalls on blood pressure medications, and I think that had more to do with the capsules and the cover, that the binders that are involved in the manufacturing process. I'm not quite sure it's really actually the medication. And so we're always concerned about, how are these medications made? I think that might have something to do with it more than the actual medicine itself.
Yeah.
Statins are present in things like red rice yeast, which are supplements that people use. So I'm not sure that the statin itself has been linked to cancer.
Someone wanted to know, is atrial fibrillation a vascular disease?
Atrial fibrillation is a heart rhythm disease. It's an electrical problem. The vascular diseases are more, if you like to liken it to plumbing. Vascular is the pipes that supply the heart muscle, and atrial fibrillation affects the electrical system for the heart.
Here's a question I have no idea. Maybe you do. You did talk about the importance of sleep and sleep health on cardiovascular disease, and actually that has now become one of the major areas that we want to address to reduce risk. But is too much sleep a risk factor for anything?
I believe it is. I believe if you get more than 9 to 10 hours of sleep, it could be an indicator. It could be an indicator of poor quality sleep. That is a risk factor. Yes.
And potentially a sedentary lifestyle, and other psychosocial issues that can be playing a role, I would assume. If this is sort of a lot of these are very personal and individual questions, and I want to skip over them. A couple of people said, like, what can I do if I have some blockage? What can I do to kind of clean it out? How do you rotor-rooter these things? Is that something that happens, or are we more just trying to stop it in its tracks so that it doesn't get worse with a variety of these medications we use?
Well, I would say that the diet actually is a bit of the roto-rooter. Again, if you're following a healthy diet, you're uh, stabilizing the plaque. I don't know if it reverses it specifically, but you're certainly stabilizing it so that it doesn't progress. And the medications generally are directed at the same thing. We want to prevent fatty deposits and we want to prevent clots, which are the two components to an acute event.
Yeah, when I tell my patients, and this is sort of old data, but there is an entity known as atherosclerotic regression. And this has been shown with aggressive lipid lowering, getting your LDL down really, really low. There's been some evidence that the amount of blockage in various arteries can actually be reduced a little bit. Okay. And we can potentially do that up to about a third of patients. In about a third of patients who are treated aggressively, we can stop it in its tracks. And in about a third of patients, regardless of what we do, disease will progress. And that's why constant surveillance and following up on a regular basis with your physicians so that we can get to it before it gets to you. And that's really the way we intervene with vascular disease. We can do things about it before it causes a problem. And so that's kind of the way I've answered that question. I'm not sure if you agree with it, but I think it's kind of ballpark correct. All right, we've reached the end of our time. I want to thank everyone for joining us this evening, and I want to thank Dr. Kulangara very much for spending the evening with us and educating us.